Hello, my name is Seenu Reddy. I'm a cardiothoracic surgeon in Nashville, Tennessee, and practice at Centennial Medical Center, which is HCA's flagship hospital in Nashville. Today I'm joined by our surgeon member colleagues to talk about some of the considerations that surgeons may want to contemplate when transitioning from a private practice model into an employed physician model. So I'm going to start off with Frank Fazzalari to my left to introduce himself.
Hi, as Seenu said, I'm Frank Fazzalari. I am at the University of Michigan. Right out of training, I was in a private practice group in South Carolina, and I made the transition to an employed model in a university setting. Mike?
Michael Moront. I'm a cardiac surgeon in Toledo, Ohio. Work for the ProMedica Health System. Was in private practice for approximately 17, 18 years, and over the last 7 or so have been involved in an employment model within the ProMedica Health System.
My name is Raymond Singer. I'm the Chief of Cardiac Surgery at Lehigh Valley Hospital in Allentown, Pennsylvania. I came out of my practice in 1992. I came out of training in 1992 and joined a large private practice in cardiothoracic surgery. Then I made an interesting move in 1999, and I became employed by a cardiology group, which was a very controversial thing at the time. We may discuss more in detail today. And then in 2004, I became an employed physician at Lehigh Valley Health Network.
Great. Well, thank you all for being here. Let me start with Frank. Can you tell us a little bit about what you've seen as some of the changes in the landscape for cardiothoracic surgeons in the U.S., particularly in terms of the employment models that they've had to deal with?
Clearly, our specialty and then medicine as a whole in this country is transitioning from a kind of a cottage industry to a more centralized, organized healthcare delivery system. It's almost like China going from an agrarian society to an industrialized society. So we're in the process now of going through some of those growing pains. In the past, most physician practices and healthcare was delivered by practices that were in a private small business situation. And hospitals were, for lack of a better term, like farmers markets, where the physicians would go and practice at the hospital, whether they be internists or subspecialists like cardiac surgeons. The hospital's job and the hospital board of directors and the entire structure of the hospital was really centered around providing a place for the physicians to practice. And in fact, the hospitals not only catered to the patients, but in a way, the physicians that practice at the hospital were their customers. As things change, as reimbursement has changed and healthcare costs need to be reined in, the cost of doing business for these small business entities, such as private practice doctors and surgeons, increased tremendously, and it was completely out of step with the increase in their revenue or the reimbursements we got. So there was a big disconnect. So therefore, it became very expensive for these small businesses, which are practices, to do business. One of the most expensive small business to run is a cardiothoracic surgery practice. A lot of overhead, employees, nurses, and such. So cardiothoracic surgery practices really felt that early on. I don't know if Mike was right in the middle of that. And this all probably came down in the early to late 90s.
Right.
Yeah, as we know that large proportion of our colleagues, now 85%, are in the employed model. You gave a very nice talk this morning about some of the compensation considerations regarding that model. Could you make a few comments on that?
Yeah, I mean, going back to what Frank initially alluded to, we found in the late 90s that all of a sudden our reimbursements were getting ratcheted down dramatically. Since I've been in practice since 1993, and by 2009, my reimbursement for a 3-vessel coronary had fallen 77%. So, with that fall and other costs,
at the same time, practice expenses were
going straight up.
So it's completely divergent.
After the ProMedica Health System hired a 30-man cardiology group, the dominant cardiology group, they thought their next logical step was to hire the cardiac surgeons. And initially we were on a work RVU model. We were happy with that for the first few years. But after we lived in that environment for 2 or 3 years, we found some flaws in it that we didn't like. The surgeons did not like the internal competition. The fact that it absolutely poisoned any type of succession model for the practice, and that the ability to hire new physicians would only be based on the fact that the existing physicians would have to take a salary cut. It also had other problems to it. So in 2014, with a lot of angst and negotiating, we got the hospital to agree to basically a salary model, somewhat based on MGMA work RVUs produced by the surgeons. And in that set, we discounted it so that it helped the hospital hedge against the future, specifically with falling reimbursement. It's a locked-in 5-year contract, and thus far, the first year of data we have, which is just this last year, the physicians were right on par, so there was no let off or back off. And respectfully, the hospital had almost 9 years of data on us, so I didn't think they were going to see it, because they knew our work ethic, and that was probably the biggest thing to convince them, is that we had a work ethic and hadn't changed in 9 years.
If I could ask, when you look back, what are some of the things you would do different? Because I think people watching this want to kind of get that gain from your experience. Yeah. What would you have done differently, if you can give some vignettes?
Yeah, from 14 on?
When you transitioned from your private practice.
Oh, from private practice, probably the biggest mistake that we made as a group, even though respectfully we got larger salaries, we had the potential for bonuses, is we did not contract with a medical contract consultant, someone who understood RVU contracting, understood the MGMA, had access to it, knew what the numbers were.
You didn't call a consult.
We didn't call a consult, exactly right, and we should have. And it cost us some money, and don't misunderstand me, we were wrong. We were relatively happy, but as into the years 3, 4, and 5, we saw problems. So when we went to go do our second renewal of our contract, we did obtain a medical consultant, and that individual was just absolutely key to us securing what we thought was a great contract.
I think that's a great point. I think a lot of us think we know a lot about our practice, but there's a whole body of knowledge regarding contracting and the legalities of it that we probably should get specialized help. Ray, you've been in 3 different settings, as you point out: pure private practice, employed within a specialty practice, and then now hospital employed. Can you reflect a little bit on some of the differences and nuances there?
Right, and I think some of the points you made are excellent about comp, and I'm going to put it in a slightly different perspective with regards to public reporting. So being from Pennsylvania, we were one of the first states, other than New York, to have public reporting of doctors' outcomes. Now, why does that play into this? Well, it gets into the concept of working or competing with your partner. So in the mid-1990s in Pennsylvania, there were 3 things that really changed the dynamic of how we work together in relationships. One was the public reporting. You take cardiac surgeons who are very competitive by nature, type A personalities, and you put their name on the newspaper with the results. Suddenly, as a new surgeon coming out, is your senior partner going to give you the easier case? Are they going to keep it for their denominator? Reimbursements plummeted, as you mentioned, so that also made more senior partners look at the younger surgeons differently. And then in Pennsylvania, they took away the certificate of need. And so every hospital on every corner was opening up heart surgery programs, and they were siphoning off surgeons to compete with each other. I saw this in the 1990s, and as I went to an employed model, both in the cardiology group and then eventually with the hospital, I actually demanded right off the top that we would not be in a work RVU model. What the hospital did for us, and the hospital does this for everybody, is not only MGMA, but AGMA and SCA to get the mean and then decide where you are. And I think the best comp model is to have a bottom, a guaranteed, and then bonuses. Today, those bonuses should not be work RVU. They should be based on value merits, good quality, citizenship, quality, and things like that. And so we kind of lived through it in the 90s, and it was very challenging. The other thing to think about, you talk about succession planning, and of course today we have TAVR and so many of these hybrid type procedures. When you want to teach your young surgeon how to do a root reconstruction, or if you're working with a colleague who's a cardiologist doing a TAVR, The work RVUs are minimal for being in that position, yet it's so important to be teaching our younger surgeons how to do these complex procedures. It's so important to be working in a collaborative fashion. So I think as surgeons go to the full-time, they should really be thinking about negotiating contracts that are non-work RVU based.
I think that's an important point is how do you compensate for non-revenue generating activities? And I think we've spent some time on the panel talking about the importance of directorships and demonstrating how surgeons add value to both hospitals and hospital systems in other ways than just in the operating room. Frank, you've been a leader on the task force in this area.
If I could make a comment to pull back to the 30,000-foot level again, and this may not hold true for academic centers, but a lot of the smaller, medium-sized community hospitals, at least in the past, and this may be changing as well, because of what I was saying, in the past, they were only tasked with essentially keeping the lights on, making sure they had adequate nursing staff, and the quality of the equipment and things like that was good. They really weren't in the business of managing, hiring, and leading physicians. What we do is extremely complicated, and they're not, at least in the past, we're not trained for this. I mean, if you look at business, General Motors, the CEO of General Motors knows what it's like to make a car, and what engineering and making cars is all about. Yet we have to, essentially, if you become employed, by definition, you are answering to hospital administrators. And they may not have the skill set necessary to properly manage subspecialists like cardiac surgeons. And that goes true for C-suite administrators and board of directors, and especially for the smaller and mid-sized hospitals, that could be a real issue. It's important that we as surgeons take the lead to educate and be leaders in that environment, because that will make a big difference.
Absolutely. I think for our surgeon viewers, can we give them maybe a checklist of the top 3 things that they should do as they contemplate perhaps becoming an employee of a hospital or hospital system?
I think the first thing is they need to seek out and get professional advice, and that can be done by speaking with other colleagues around the country, even cardiology colleagues. I mean, a lot of groups have gone through this transition, and there are people out there that can easily switch from cardiology and gastroenterology and nephrology back to cardiac surgery. The numbers are different, but the game is the same. Mm-hmm. I think being a group, if you are a group rather than an individual surgeon, that's important. There's strength in that number. Absolutely. Very much so. And I think you need to be willing, as a group, to work collaboratively with the hospital on cost, efficiency, risk sharing, a co-management type of a thing. And finally, I think quality is going to trump everything. You have to have good quality. You have to be responsible for your results. You have to be honest and transparent, and try to improve upon them. I think that's good. And if you do those things, you'll most likely be very successful with your model.
Right.
I think by nature, there's always been a seemingly adversarial relationship between doctors and administration, and I think we have to get past that. Just as we have to collaborate with cardiologists and with intensivists and with each other, I think it's important to recognize that the hospital wants us to do well. They want us to have good citizenship. They want us to have good quality results. The hospital has a lot of resources, and I would seek them out, and I would work with your hospital, and you will do a lot better. Yes, you lose a little autonomy. So when you think you need another physician assistant, they may say, well, we don't think so. But what you need to do at that point is then justify it based on your volumes, based on quality, based on program development. And you need to do your part. So our bonus plan, for example, includes citizenship, including doing outreach. So the surgeon has to do a minimum of 2 outreach efforts to referring doctors every 6 months, and getting involved on committees like the QA committee at the hospital. I think you need to embrace the hospital, and remember, they're like the owners of your team. If you were in a football team, those are the owners, but they want you to win. and you just have to learn to work with them.
It's a great analogy.
One other thing, I think one thing that's been very, very helpful with us is that the last 3 CEOs of the ProMedica health system I've been good friends with. We've gone out socially, our wives know each other, we've done other things, and I think that breaks down a lot of barriers. I mean, I don't pick up his cell phone number and call him very often, but when I do, he takes my call. And I think that's a critically important thing, as opposed to, again, being adversarial. And the other senior administrators, I don't bug them for junk, but I bug them when I need them, and they listen to me.
Frank, you got some top
I
three?
think those are all excellent points. I want to maybe highlight one thing that Mike said. From a strategic point of view, it is helpful if the surgeons are together. It's difficult if there's other surgeons that are working independently. It's very difficult to have leverage or have any kind of power in a negotiation situation. So it makes a big difference if the group, such as it is, or the surgeons that are available to that health system, are on the same page and working on the same team and working together. Strategically, from a negotiation standpoint, that's very important.
I couldn't agree more. I think a couple of the top 3 ideas that came across my thoughts were, number one, I think it's very important that you do get some legal review for the actual contract. I think it's important to have a good employment lawyer look at that contract to make sure you've got your I's dotted and T's crossed. I think on the compensation structure, there's so many out there, and it's not wrong to explore them. Look at what might be the best fit for your group. And then, of course, the third is make sure that the value proposition is more than just the compensation. I think, like you pointed out, you really have to show the hospital system and administration that you're bringing a lot more to the table than just the case mix and case volume.
Absolutely. And I think in this day and age of quality metrics, that's a natural for heart surgeons. Of course, we have our STS database, and we're really known throughout all of surgery as being a specialty that really gets quality. As I said, I've been living with public reporting in Pennsylvania since 1992. That is something, as we go from volume to value, that your hospital needs help with. And that's something that cardiothoracic surgeons really know a lot about. That's a type of citizenship that you can give back to the hospital. It'll make your value to them greater, and everybody wins.
Any parting thoughts?
It's all about personal relationships.
It really
Absolutely.
is. It
And
really is all
whether
about
it's with your partners, your referring doctors, and or the hospital, it still comes down to personal relationships is what makes us successful.
Well, thank you all for being a part of this panel.
Thank
Thank you very much for us.